This is the Gerontology Conference Project for Nursing 321, Gerontological Nursing and End-of-Life Care at the University of North Carolina at Wilmington. This is a group project where we're discussing delirium in older adults, specifically the recognition, treatment, and patient outcomes for delirium. This presentation covers several pertinent articles that are in the literature covering the topic of delirium in older hospitalized adults. The first one is from Mark Antonio, which discusses the topic of delirium and sets the stage for further articles that are going to be presented. Delirium, which is characterized as altered mental status, is a common consequence of hospitalization, affecting a third of hospital patients over the age of 70. And over half of hospitalized patients over 70 will have delirium upon admission. So it is very prevalent. Delirium is a primary surgical complication seen in older adults, affecting 15 to 25% of elective surgeries and 50% of high-risk procedures such as cardiac surgery or hip fracture repair. 75% of ICU patients that are on a ventilator will experience delirium, and 10 to 15% of emergency department admissions of older adults present with delirium. And end of life, the presence of delirium can be very high as 85%. Identifying delirium in at-risk patients is important for prompt intervention. Nurses are at the forefront of patient care and can help identify cues that a patient might be experiencing delirium. There are two types of delirium: hyperactive, involving symptoms of agitation, and that accounts for 25%, and the more common type, or hypoactive, which accounts for 75%. Delirium is a mental state of acute confusion caused by baseline, which would include predisposing, as well as acute or precipitating conditions. The more baseline factors that are present in an individual would mean that there are fewer acute factors that are needed to cause delirium. So accurate diagnosis is important in treating delirium. Hypoactive or quiet delirium often presents with signs that may not be as outwardly visible and thus might go unnoticed or undiagnosed by healthcare providers. Tools that nurses can use at the bedside are numerous. The one that's used quite a few articles that I'll be discussing is the Confusion Assessment Method, or CAM, but there are other alternative methods. There's a 3-minute diagnostic interview for delirium, confusion assessment model or method for the ICU, a brief confusion assessment method for emergency departments. And this talk is not going to really go into all of these or the specifics for how they're done, but the purpose is just to mention that there are quite a few techniques and tools that are available for nurses to use to help screen patients for the presence of delirium. It is critical that delirium, especially hypoactive delirium, is identified early and treated, since patients with hypoactive delirium often have poor prognosis and long-term outcomes, and because the signs and symptoms are not as outwardly visible, they may not be recognized. Certain drugs pose a high risk for delirium, so medication review for patients that are exhibiting signs and symptoms of delirium is essential, as quickly reporting behavioral changes to physicians. Reversible causes of delirium, including the use of non-pharmacological methods to reduce agitation, including distraction and de-escalation, are useful. And the use of less psychoactive drugs and eliminating the cause of acute delirium is the key to resolving symptoms of delirium. Delirium is a significant medical condition since it's an independent predictor of mortality in older adults and is associated with prolonged hospitalizations, complications, and long-term disability, as it also causes increased medical costs. Understanding precipitating factors for delirium can assist nurses in identifying which factors can be altered to decrease the risk of delirium, including sedation, such as hypnotic and anticholinergic drugs, anesthesia, infections, anemia, high pain levels, and acute exacerbation of a chronic illness, which can be altered or removed. Precipitating factors can also be removed if determined to be present in patients with acute delirium. Nursing care for patients experiencing delirium includes removal and/or treatment of the underlying organic cause, reorientation to the patient's baseline cognitive level, and promoting adequate nutrition, hydration, elimination, and sleep. So traditionally, delirium is thought to be a transient condition, and patients who suffer from delirium are expected in general to make a full recovery as the underlying medical cause is treated and symptoms will dissipate. However, in older adults, delirium is associated with significant cognitive impairment and functional disability. Can also include longer hospital stays, even institutionalization, and death. One study that looked a little bit more closely at delirium was conducted by Cole and his colleagues on a medical surge inpatient unit for patients that are 65 and older with delirium. And it was noted that only a minority of patients were able to fully recover from their bout of delirium. Those that suffered dementia had even a smaller incidence of full recovery, and this revealed the severity of delirium, and the longer the symptoms lasted, the less likely they were able to recover. This was reported in a meta-analysis, and a meta-analysis basically is a summary of various multiple scientific studies which showed that 45 to 33% of participants with delirium had no recovery at discharge from hospitalization at 1 month after. And this is really significant for modern nursing practice due to the advanced age of the average patient. If an acute onset delirium can increase a patient's risk of developing dementia, it's also of significance in nursing care. So what does that mean for nurses is that the sooner that we can recognize and treat symptoms, the more likely the patient will be able to recover. So follow-up is just as important as assessment in looking at delirium in the hospitalized older adult. Perhaps once initial symptoms of delirium dissipate, follow-up assessments may not be done routinely as they should. So the patient may have lingering symptoms that may not be recognized, and it might be a little bit of a stretch, but in some cases, elderly patients, it might be argued, are dying as a result of delirium. So it's very important to look at this in terms of developing an evidence-based practice. Questions we should address include, what are we missing? How can we better recognize early signs of delirium? And are the interventions that are being used, are they really best practice? And we really need to ask that question, especially in cases when there is actually greater cognitive impairment and even evidence of death. So in a study conducted by Cole and his colleagues, only a minority of participants fully recovered from their bout of delirium. Those that suffered dementia had even a smaller chance of full recovery. The greater the severity of delirium and the longer that the symptoms lasted, the less likely the patient was ever able to really fully recover. And according to the study by Cole, dementia is the strongest risk factor for the development of delirium. Having delirium will increase your risk of dementia, and the presence of dementia is a risk factor that would contribute to incomplete recovery. So this study proves that delirium needs to be quickly recognized and aggressively treated, especially with the older adult. Delirium in the hospitalized older adult, non-pharmacological interventions. A study by Rivosecki, Smithberger, Sveck, Campbell, and Kane-Gill in 2015 found that multi-component intervention protocols can be used to combat delirium and have proved beneficial. And in fact, multidimensional protocols reduced delirium by 15.9% as compared to protocols that had 2 or fewer interventions, which only reduced delirium by 11%. On the basis of guidelines and recommendations in the literature, these protocols should include early mobilization of hospital patients, education of nurses, and cognitive stimulation with reorientation. All studies that included mobilization, noise reduction, or sleep protocols displayed early patient mobilization. Mobilization can be as complete as full physical or occupational therapy treatments, or can be simply passive range of motion exercises. Bedside nurses and other members of the medical team work together to decide the level of mobilization a patient can complete. Nurses can be advocates for the removal of tubes, catheters, or restraints which may prevent early mobilization. And the prevalence of delirium is reported to be between 11 and 42% for general medicine patients and up to as high as 87% of ICU patients. So this necessitates the need for delirium screening and treatment protocols. Prompt intervention can decrease the severity and duration of delirium. Ragosecki et al. Found that the development of delirium in critical care patients is associated with an increased stay in the hospital of up to 15 days. Hospital costs, which can accumulate nationally per year of up to 4 to 16 billion, and a 19% increase in 6-month mortality rate. The same study found that non-pharmacological management of delirium among the hospital patients had the ultimate goal of being able to identify which strategies are going to be beneficial with the intent of developing a non-pharmacological protocol that could be implemented with critically ill patients. Non-pharmacological techniques to improve delirium among the elderly is important, especially since medications can have adverse effects, in particular on the elderly. DeWitt et al. Has studied the associated risk factors for patients over the age of 60 using electronic chart data that would be part of a routinely entered information that would be gathered by a physician or nurse. And this has been used by data analysis with an algorithm to predict increased risk of patient delirium. And this model is called a clinical decision support system that this article talks about. So based on the algorithm, they can predict a model that would aim to assist an interdisciplinary team in preventing delirium before treatment is necessary. So the idea is if you can identify a patient at risk for delirium before they actually present with symptoms, this can aid in early treatment and a better outcome. So they looked at the use of a CDSS, or Clinical Decision Support System, as an aid in predicting and initiating preventive care. So further looking at a Clinical Decision Support System, or CDSS, is interesting and important because nurses deal with delirium on a daily basis and are subject to frustrations caused by delirium, both in terms of the patient outcome as well as with our daily workflow. So to further assess if a CDSS can be used as a predictive model, DeWitt et al. Looked at a retrospective cohort study for patients that were admitted from 2008 to 2012 in a Dutch teaching hospital using defined inclusion and exclusion criteria for dementia. And of these patients, of the 646 screened delirium patients, 225 made the inclusion criteria. And for the study, there were also 1,066 patients that did not have delirium that were included as a control. With this analysis, they looked at 26 possible risk factors for analysis, and these risk factors were further divided into a medication model, which emphasized the use of prescribed medications, and a full model, which also include two other criteria, that for C-reactive protein, or CRP, which is often used as an index of inflammation. So we thought that maybe infection or inflammation could predispose a patient for delirium, so that was the rationale for CRP, and urea, which is a marker of kidney function. So the idea is that patients who have impaired kidney function might have buildup of toxins and waste products in their bodies and could be predisposed to delirium. And so from this study, there were some limitations in that it wasn't totally comprehensive. There were some more data points that were missing and some improvements in the model that needed to be made. However, the authors of this paper did propose that their findings were clinically relevant. So with the CDSS model, I just wanted to have a slide that showed the differences between the medication model and the full model. The medication model had 10 variables, and the variables listed here are V1, age, V2, polypharmacy, V3 through V10 indicate several different medications, such as anxiety medications, depressive meds for depression, for psychopharmaceuticals, analgesics, etc. And then the full model included 2 additional lab values of CRP and urea. And without getting into the math portion of it, I just wanted on the right-hand side to show just more clearly that the full model had 12 variables, V1 through V12, with different weighted ratios. And the medication model had only 10, excluding variables 11 CRP and variable 12 urea. The results of their study showed what the medication model had a sensitivity of 78.2 and a specificity of 63.7. And in statistics, sensitivity would refer to the ability of a test to correctly identify a disease or an outcome. So if this variable directly relates to the outcome of dementia, then you would say it is 100%, specific, or sorry, it'll pick it up. So I reverse that. So it'll pick it up. If it's sensitive, it will pick up that result, and it will not have any undetected false negatives, whereas specificity means how specific is the test to dementia. Would it not encompass other things? So, for example, analgesics, could be specific as a risk factor to dementia, but it could also be to other outcomes or diseases. So the higher that you are at 100%, the better. So this shows that the model can use a little bit of work with specificity, or being able to be specific just for an outcome of dementia. But the authors did state that they thought that their test was clinically useful and clinically relevant. So one thing to note with some of the variables that were used in the predictive model, if we look at these predictive variables, if you look at the univariable analysis number, which is in the the third column, it shows how useful it was as a variable in predicting delirium. So this was analyzed using p-values. So if you have a p-value of less than 0.05, it means that it is statistically significant. So a low number means that it was meaningful in predicting delirium as a variable, and if it's a high number, then it means it wasn't really impacting of a variable. So variables that showed influence or impact for as a predictive variable include age, polypharmacy, presence of or use of anti-dementia medications, anti-Parkinson's medications, pharmaceuticals that are involved in psychiatric disorders, and that would be it. So as I mentioned earlier in the presentation, that CRP and urea were included in the full model, but not in the medication model. If you look at the p-values for these, they did not show that they were significant. They were greater than 0.05, so they did not show influence on the development of dementia. Also, this model, part of the 26 variables, also included a few lab values such as sodium and potassium, glucose, but they were not included in the final model of either the medication or the full model as part of the CDSS algorithm. So another interesting aspect of delirium is looking at delirium in the hospitalized older adult, especially in the cases where they already have dementia. And this is a special situation where you have delirium superimposed on dementia, or DSD. The delirium is more common in older adults that are hospitalized and can be worsened when patients have baseline dementia. So in one study that looked at DSD, it looked at being able to quantify the combination of dementia and delirium's effect on mortality at set intervals, especially at hospitalization and long-term at 12 months. The authors of the study attempted this work to really look at the prognosis of delirium, especially DSD compared to delirium itself. And patients that have delirium alone or DSD are going to have a higher hospital mortality risk than patients without delirium. And different comorbidity risk factors will include functional status, nutritional status, vital signs, polypharmacy, kidney function. So different lab results will be looked at, such as GFR, albumin, and urea, and inflammatory markers. So in the study, dementia alone did not correlate with a high hospital mortality unless it was also accompanied with delirium. However, presence of dementia may lower the threshold of triggers which could set forward delirium to set in. So patients that have dementia might be more vulnerable and at higher risk for developing delirium. And this study was pretty preliminary, and further studies of DSD relative to delirium alone or dementia alone should focus on the duration and severity of delirium, signs and symptoms, and whether there needs to be a different treatment strategy for treating DSD versus other types of delirium. Delirium in the hospitalized older adult, relationship of cumulative physiological dysregulation and delirium. So acute and chronic stress can result in changes in physiological function. And the degree to which this occurs, there's a term for it called allostatic load, or AL. Researchers have investigated how AL levels correlate with the development of delirium in older adults. A factor in whether AL results in changes to maintain physiological balance or homeostasis is called homeostenosis. And so homeostenosis is an age-related impairment of homeostasis. Participants aged 65 and older who are admitted to the hospital were screened using the standardized mini mental status exam, or SMME, in order to measure their baseline cognition, and a second exam called the Confusion Assessment Method, or CAM, was used to assess these patients for delirium. Participants were not included in the study if they had existing severe cognitive dysfunction or delirium. Incident delirium was assessed 48 to 72 hours after admission. The results of the study showed that 29% of delirium occurred among older adults that were hospitalized with a mean age of 75. So delirium that is seen in the hospitalized older adult has pathophysiological causes. So these have to do with neurotransmitters and the brain. Why we have a picture of the brain in the center of the slide. Delirium has been associated with increased morbidity and mortality, and this ultimately increases healthcare costs. Delirium is associated with declining functional and cognitive abilities, which can cause psychosocial distress not only for the patients but as well as their families. So one neurotransmitter that's thought to be involved is acetylcholine. So a cholinergic deficiency can be associated with delirium. And acetylcholine will regulate arousal, consciousness, and attention. And it is argued by researchers that perhaps this can account for impairment in cognition and attention. And dopaminergic receptors, on the other hand, have been linked to a role in delirium and can regulate possibly the release of acetylcholine. So medications such as levodopa are believed to precipitate delirium, and then medications that are dopamine antagonists or antipsychotic agents can be used to treat delirium. Allostasis is a term that can be used to describe a wide variety of variability that is seen in psychological parameters of regulatory systems as an integrated response that indicates healthy functioning related to stress. So we have some stressors that if you respond to are actually healthy, and other ways they could be unhealthy. Regulatory systems are influenced easily by overload, and dysfunction can include stressful exposures. Allostatic load and delirium in hospitalized elderly, or ALDHE, is a model framework for understanding delirium. It can be used in considering the effects of allostatic load on aging and delirium development. The allostatic response basically is a nervous system response in which physiological systems are activated. So on the right-hand side, we have a diagram looking at the effect of chronic and acute stressors on allostasis. So chronic stressors would include genetic factors, lifestyle factors, environmental factors as well, general state of health, any major life events, and perception of situation and events. Acute stressors can include hospitalization, infection, inflammation, hypoxia, metabolic disorders, medications, sensory or sleep deprivation, and immobilization. So all of these factors go together to activate the autonomic nervous system and neuroendocrine systems, and if there's a maladaptive response, this can result in homeostasis. So allostatic load looks at the composite of all of these factors and can either result in delirium or no delirium depending on the adaptive response. Allostatic load was measured based on primary mediators. So these are a lot of hormones such as urinary cortisol, epinephrine, norepinephrine, and serum DHEAS, and that's abbreviation for a hormone that's produced by the adrenal glands, as well as secondary mediators, which are more of the physiological effect of these hormones, such as increase in diastolic and systolic blood pressure, glycosylated hemoglobin, triglyceride levels, or triglyceride to HDL levels, and hip waist to hip ratio. Acute and chronic stress can result in changes in physiological function, and the degree to which this occurs is called the allostatic load. Researchers are now just beginning to investigate how that would correlate to the development of delirium, especially with older adults. Allostatic load and delirium in the hospitalized elderly can be looked at looking at the measurement of mean allostatic load scores. So I have the paper showed a graph on the far left of allostatic load. The dark bar far left is the total sample, and we can see the middle bar is for patients with delirium, and the right is for those that do not have delirium. So the overall allostatic load is higher for patients with delirium versus those in the total sample or those without delirium. And if you look at the middle bar graphs for primary mediators, those show that they're higher in patients that have delirium versus those that do not, although that the secondary outcomes are lower for those with delirium. So from this means that the primary mediator scores were observed to be predictive of the incidence of delirium in the elderly. Primary mediators measure chronic changes over a lifespan, and they also look at acute changes such as physiological and psychological stress, fear, and disease states. Interestingly, older adults exhibit longer periods of time from when they might have elevated primary mediator levels to when they would return to baseline. And so because, for example, if they have an increase in epinephrine or norepinephrine due to a stress state, those hormone levels are going to remain elevated higher before coming down to baseline versus a younger individual. And it is believed that that increases the risk of delirium. Delirium in the hospitalized older adult is a serious condition that has both underlying predisposing as well as precipitative factors. Prompt screening, recognition, and treatment is important in improving patient outcomes. Not all patients make a full recovery from delirium, especially patients who have dementia or patients experiencing prolonged duration or severity of delirium. Non-pharmacological approaches should be tried first, including reorientation, cognitive stimulation, and early mobilization. Models for assessing the pathophysiology of delirium, including the allostatic load, are currently being researched. Protocols such as the Clinical Decision Support System, or CDSS, have been proposed for the development of screening protocols that use patient data collected during an assessment in order to calculate patient risk for delirium development. This ensures early treatment and intervention. Recent literature illustrates the importance of recognizing and screening hospitalized patients for delirium, since only 12 to 35% of delirium cases are actually accurately diagnosed. It is a priority to quickly recognize delirium, especially by nurses, since this can further result in cognitive decline, increased length of hospitalization, and long-term impairment if we fail to recognize the signs and symptoms.